So there are a couple of very specific projects that we've done, but a lot of the time what clinical support services are doing is listening and talking to the care groups who are making, and the service lines who are making the really big changes, and seeing what we can do to support them and what they need and how what their needs are going to change going forward. So yes, so we were asked by cardiology whether we could support hot clinics for cardiac chest pain. And so what we are doing is we are changing 2 mornings a week when we would normally do outpatient cardiac CT to be 8 patients each morning for hot clinic patients. These are patients who've come into the emergency department or admission avoidance, SDEC, or onto the medical wards, who have been reviewed by the medical take and cardiology and felt that they are a low enough risk to go home safely and be seen within a couple of days in a clinic with a cardiac CT. So that's quite a big change, and what we're hoping is that will reduce the number of patients who are sitting in inpatient beds waiting for a cardiac CT, and that it'll streamline that process and increase the confidence of the doctors who are seeing these patients really early on to let them go home. So there's a pilot going on at the moment in the surgical assessment unit about point of care testing. So this is where you take a sample which, instead of going off to the laboratory to be analysed, it's analysed in a machine on the ward. The results are available within about 20-30 minutes rather than an hour, and they are available right there in the notes for the doctor to come and see the patient with the results. And although it's a little bit more expensive, and although it requires more time for the staff on the ward to take that blood, go to the machine, wait for the analysis, put it in the notes, we are reasonably confident that it is going to reduce the amount of time taken for those results to be available for a doctor to make a decision about that patient. And so that pilot is already in progress in SAU, and we're going to then reinvigorate some of the work that's been done in ED, move the pilot onto the medical admissions unit and reinvigorate what's being done, streamline what's being done out in the urgent treatment centres, and hopefully offer them some more tests. So again, prevent patients from needing to come up to Derriford main site for a blood test. The point of care testing is something that's come out of the laboratory staff, the DCL. That's something that they have driven. So that's entirely driven by CSS. So, for example, there's another project going on about an X-ray in a car that goes out to people's homes to take pictures of legs and hips and what have you, so that this is particularly for very frail patients who probably shouldn't be coming onto the main site, shouldn't really be being admitted. And if we can go and do an X-ray in their home, in their nursing home, and demonstrate that there isn't a fracture, or there's a fracture that wouldn't need an operation, can be managed conservatively, then that's a great bonus to them, great benefit to them and to the hospital. So the work to agree who's going to take those X-rays, what the equipment can do, what kind of service we should be offering, and all the legal bits and pieces around taking X-rays at different locations, because it's not straightforward. All of that work is happening within CSS, but we're not yet out there taking pictures. And a similar pathway would be the fast track for patients with a potential neck of femur fracture. So these are usually relatively elderly, relatively frail patients who've fallen, and we think that they fractured their hip. And the new pathway is that they come in straight from the ambulance or straight from triage, have an X-ray, and if they've got a fracture, they go straight up to the ward.